Hello everyone, welcome to AETSM Amrita Emergency Medicine channel. I am Dr. Riyaz Ahmed. Today I will be dealing with rapid ultrasonography for shock and hypertension, commonly known as the RUSH protocol. What's RUSH protocol? It's actually a complete RUSH examination in a standardized diagnostic approach for the patients who have unexplained tachycardia, tachypnea or hypertension or are in complete cardiac arrest. And to identify any potentially treatable causes, mainly such as abdominal aortic aneurysm or a pulmonary embolism or congestive heart failure, sepsis, ruptured ectopic pregnancy, hypovolemia, pneumothorax, hemothorax or a hemoperitoneum. In RUSH protocol, entire circulatory system, it can be divided into mainly three parts. The pump, of course it's the heart, then the tank. In the tank, mainly we can assess the fullness of the tank by assessing the inferior vena cava, and whenever the tank is empty we have to go for a fast. Then finally the third component, the pipes. So pipes, mainly it involves the leaking of pipes by ruling out the abdominal aortic aneurysm or a blocked pipe by ruling out a DVT. Next, now I will show you a slide on where to scan while doing a RUSH protocol. So the sequence of RUSH examination is: first one is look for a parasternal long cardiac view. Second one is apical four-chamber cardiac view. Third one is inferior vena cava view. Fourth one is Morrison's pouch along with an hemothorax view. Fifth one is splenorenal view along with a hemothorax view. Sixth one is the bladder. Seventh one is the aortic view, and eighth one is eighth and ninth are the to rule out pneumothorax on both sides. First we will deal with the pump, that's the heart. Mainly three things we have to look into cardiac ultrasonography. First one, we have supposed to rule out cardiac tamponade. We are supposed to look for free fluid around the heart, but we should be careful not to mistake for anterior fat for free fluid. Then we have to look for the cardiac functional status. It can be done by assessing the mitral valve motion in a parasternal long axis view. In details I will show you later. Then we are supposed to assess both the ventricles, that is the right and left ventricles. Usually right ventricles will be visibly smaller than the left ventricles, but it may not be the same in conditions like long-standing COPD or a pulmonary hypertensive patient. I am discussing the cardiac parasternal long axis view or the PLAX view. PLAX is the most commonly used view while doing a cardiac focus. Usually the probe is kept at the ECG lead V2 position, that is around the third intercostal space, and we can adjust accordingly. PLAX views is very good for identifying cardiac function. Now I will demonstrate cardiac parasternal long axis view. Orient the probe towards the right shoulder in cardiac mode and keep the probe over the ECG lead V2 position. This is the PLAX view. Here we can see the left ventricle, right ventricle, mitral valve and the aortic valve. In this patient, he is having good cardiac contractility with no regional motion valve abnormality. The mitral valve slapping the septum is also a good sign of cardiac function. This cardiac subsephoidal view. It's a mainstay of cardiac focus, and it is commonly during the fast examination, and it is more sensitive for pericardial fluid detection. Keep the pointer directed towards the right side and use a scooping motion to get under the xiphoid. Here we can see that this is the right ventricle and this is the left ventricle, and this is the right atrium and this is the left atrium. Notice that the right ventricle is always on top and is smaller than the left ventricle. Next is the apical four-chamber view. For a better view, it's better to slightly shift the patient to turn towards the left side. Here the probe is positioned at the apex of the heart, usually approximately 5 o'clock on the male patient's left nipple or laterally beneath the left breast at the apex of the heart on a female. In an apical four-chamber view, we can see the left ventricle, interventricular septum, right ventricle, left atrium, and this is the right atrium. Here we can see the mitral valve, and here we can see the tricuspid valve. Now we will discuss various scenarios. First I will show the slide showing the cardiac tamponade. Identifying the cardiac tamponade is one of the most valuable use of while doing a point of care ultrasound. I have shown an image showing the cardiac tamponade. You can see fluid accumulation above the left ventricle and the right ventricle, and you can see the entire heart is floating in a fluid pouch. In the right side we have another diagram along which the more fluid is more accumulated over the left ventricle. It's a graphical representation what happens while there is a cardiac tamponade. In diastole, the right atrium is getting collapsed, while in systole the left ventricle is getting collapsed. We can look for this collapse while doing a point of care ultrasound. Next important clinical condition is pulmonary embolism. How to rule out pulmonary embolism? So, while doing an ultrasonography to rule out pulmonary embolism, what are the things that you have to look for? First, I will say about the right heart. In right heart, look for right ventricular dilatation, right ventricular dysfunction, that will be global or regional wall abnormality, an acute onset of tricuspid regurgitation, or a decrease in right ventricular fractional area changes. Then, in the left heart, look for normal or a hyperdynamic left ventricular failure or a paradoxical septal motion. And while looking in the vessels, the pulmonary artery will be dilated and attenuation of a normal inspiratory collapse of inferior vena cava. In the diagram, I have shown the underfilled left ventricle. In the parasternal short axis, we can see the D sign. In the dilated right atrium and right ventricle, along with the McConnell sign in the left lower image, and along with that acute onset of tricuspid regurgitation on the fourth image. Next is estimating the ejection fraction. But it's not an accurate method, but we are in point of care ultrasonography, it's possible to pick out the extremes of cardiac function. First, I will discuss a normal cardiac function. We can assess the normal function by assessing the mitral valve motion. Good mitral valve motion is an indicator for a good ejection fraction. We can measure the EPSS, that is end point septal separation. That's the distance from the tip of anterior mitral valve to the septal valve. We can measure it in a M mode, and in EPSS value more than 10 indicates a good ejection fraction. Next is, while if you are looking at a very poor cardiac function, that is a patient whose heart is in heart failure, in the graphical representation I have shown that the entire contraction of the wall is very less, that is the ventricles are not at all, the walls are not at all approximate. So in this is how the motion of a poor heart will be visible in an echo. Now last is the patient who is in hyperdynamic circulation in conditions like sepsis or hypovolemia. Here, if the contractility is increased in such a way that the ventricle walls will be touching each other during the systole.